My name is Nicole Georggi, and I'm a Master of Science here at the Duke Global Health Institute. And I want to start out with a definition of health. In a Lancet article co-authored by Dr. Michael Merson, global health is defined as a field of study, research, and practice that places a high priority on achieving health equity for all people. I can say with confidence that my time at Duke has really been an intersection of the three. Over the past year, the coursework I have taken has submerged me into the study of global health, enabled me to create and design qualitative research projects, and equipped me with the skills necessary to put that project into practice. In 2011, the Duke University Moy University Comparative Health Research Twinning Program was formed. Led and developed by Dr. Wendy O'Mara, this program partners an MPH student from Moy University in Eldoret, Kenya, with a Master's of Science student from Duke University. This past year, I was fortunate enough to be an inaugural member of this program and work with my research partner, Shireen Adipo, to investigate the health of United Methodist Church clergy in Western Kenya. This study is a small part of a larger ongoing study here at Duke, the Duke Clergy Health Initiative, which is led by my research mentor and thesis committee chair, Regine Prochel-Bell. This study at Duke has been investigating the health of United Methodist pastors here in North Carolina for the past few years with a mix of qualitative and quantitative methodology. So you may be wondering why the study of clergy health is an important topic. And I just want to share with you some things that we found to be important, and then some things that we don't know about clergy health. So we know that clergy are a very dynamic group in the population. They point people to God, they help navigate social and spiritual waters, they give advice and guidance to parishioners and make hospital visits and do funerals and just have a very busy schedule. We also know that compared to the general population, clergy often have worse health outcomes in terms of diabetes, obesity, and other chronic diseases. Clergy have had higher rates of those. And one of these reasons is because as caregivers and counselors, clergy often neglect their own health to take care of the health of others. And due to their hectic schedules, lack of social support, and job-related stressors, their health has been neglected. So, although we know this about the health of clergy in the US and Canada and Great Britain, very little has been documented about the health of clergy internationally. We do know, however, that religion plays a very important role in the lives of people all over the world, and East Africa is no exception. So, Africans traditionally do not compartmentalize religion and health, but see the human being as a holistic unit, as one person made up of many parts. Because of this, clergy have an even more significant role in the lives of Africans, and they're no longer seen as just preacher and caregiver, but as healer and community leader as well. So to better understand this, Shireen and I traveled to Nyanza province in Western Kenya, where a large concentration of United Methodist clergy live and work. We became participants in the community. We attended church services, held and led community meetings, and shared meals with pastors there. Additionally, we conducted 4 focus group discussions and 9 in-depth oral interviews with a total of 49 pastors in that region, and had a really cool results. Shireen looked at the barriers and facilitators to health-seeking behavior, and I looked at how clergy conceptualize health and how that conceptualization may affect the way that they seek healthcare. And I don't have time to get into all the results of my study, and I would be happy to talk to you about that after this session, but I did find that indigenous cultural traditions and religious beliefs impact how clergy conceptualize health, and that conceptualization affects good and bad how and when they seek medical attention. This is a picture of Shireen and I with 2 different sets of focus group participants in Kuroka, in Nyanza province in Kenya. She led one and I led one that day just because we didn't have a lot of time, but that's what that picture is of. And I want to thank DGHI and the Duke Clergy Health Initiative and Moy University for giving me this opportunity to learn about clergy both here and abroad. So, thank you.
Questions for Nikki? She's defending her thesis this week, so she needs some really hard questions.
How much interventions for health among clergy differ from interventions among any group of adults?
That's a great question. And we didn't look at health interventions for this specific study, but I do know that the Duke Clergy Health Initiative has formed a holistic intervention that incorporates some spiritual aspects in addition to what a regular intervention would incorporate. And in Africa particularly, because they view health so holistically, I think having a spiritual component to an intervention would be of particular importance and couldn't be left out. And I think most health interventions may not have a spiritual component. So. Oh.
Go ahead, David, sorry.
Nicole, you said that specific indigenous beliefs played a role in conceptualizations. Could you give us a few examples of those?
Sure. So I spoke with the Luo and Kisii tribes specifically in Western Kenya, and they still hold very strongly to the sorcery, witchcraft, magician type of beliefs. And I maybe naively thought that that may not be very integrated into Christian beliefs, especially for clergy members. I thought that might be a little bit separate, but that was not the case. If anything is related to an evil spirit, an evil eye, anything that has to do with a disease that could be a result of magic or witchcraft, the clergy still seek medical attention from the local witch doctor instead of seeking it from the traditional modern medical doctor, I guess. So that was still very much alive and is very integrated into their Christian beliefs.
Do you think this is kind of a good representation of all different denominations of Christianity in Kenya? I realize that you focus on Methodist, but did you think that this was kind of a good case study for all denominations, or do you think it was different then?
Yeah, that's also a very good question. I think it may be a good case study depending on the tribes, because I know different tribes have different cultural beliefs and different ideologies, and so maybe different denominations within the Kisii and Luo this could serve as a case study for, but I'm not sure if we could extrapolate it across all of Kenya and all denominations and say that that holds true. I would be interested to see if that is. I think some of the beliefs would definitely hold true just because they share nationality and some background things, but.
So you saw like the tribal connection as being more important than the specific Christian.
And even within this region, there wasn't very much tribal differentiation that I found within their beliefs. Our focus group had a mix. Our first few focus groups had a mix of different tribes, and then our last two were very specific because we were in specific regions conducting them, but there wasn't a huge diversity in answers, although in Kuroko, where we conducted this focus group, the indigenous cultural beliefs very much came out a lot more than our first focus groups. Also, by that time, we had a longer kind of community relationship with them, so maybe they were more open with us by then, I'm not sure.
I'd like to ask everyone, when you ask a question, to please speak. I could repeat the questions, but I think we're in a small enough room that if everyone could just please speak up so everyone can hear. Eve, did you have a question?
You mentioned that here in Durham or in the U.S. there's a health disparity between clergy and then other communities. Did you notice that, or did you ask about that?
So that's a great question. The Duke Clergy Health Initiative found that through quantitative surveys, and they actually asked very specific questions about diagnoses. Since our study was exploratory in nature, we basically just looked at how clergy conceptualize health and religious and cultural traditions that impact that health seeking behavior. And even from just observations, I didn't see a real difference in the health of clergy compared to the health of other people, although, and I didn't get into it here, they were much less likely to seek medical care because they were afraid that members of their congregation would see them, or they also had a very firm belief that God alone saves. And I don't know if that is true, because we didn't interview anyone except clergy, if that's true for everyone in that region or if that's just true for clergy. But the idea of not wanting to go get HIV tests or whatever because they were afraid of community perceptions could make them less healthy, obviously. And they also saw those as moral diseases instead of infectious diseases. So they're, in that case, in that sense, yes, but no one disclosed to me that they were suffering from diseases, so I couldn't see that.
Do you think that this study would make an impact on them and bring about any lifestyle changes?
I don't know about lifestyle changes, but we are hoping to make some changes as a result of this study. I know I've been working with Ray Jean, my mentor, and with some people here at the Duke Clergy Health Initiative to see different types of options for health insurance and for different training programs. None of the clergy there have salaries, which I found was very true of most of clergy in almost all denominations in East Africa. And because of that, most of them do not opt into the National Health Insurance Fund that's in Kenya, which also is a reason that they don't seek healthcare, because it's really expensive if they have to go each time and pay an exorbitant rate. So we're trying to look at some of those options, and I would love to do follow-up studies and interview clergy wives and congregation members, or do quantitative studies and see if there is a disparity between clergy and their congregants. But I don't know what the future holds, so I hope to do that.
Okay. Thank you, Nikki.